HSSR Research in Progress Series webinar. Our theme today is Bridging Health and Healthcare. The title of our presentation today is Identifying and Learning from Positive Deviant Local Public Health Departments in Maternal and Child Health. Our presenter today is Tamar Klaiman. Tamar received one of our PHSSR Mentored Research Development Awards. These are two-year awards that provide protected time to complete a PHSSR project with both a research and practice mentor. We'll have 4 award recipients present over the next 6 weeks. Tamar is our first recipient. March 4th, we'll have Brian Dixon, PhD, present. March 11th, Erica Martin, PhD, will present, and then on April 1st, Helen Wu, PhD, will present. Those will be our 4 mentored researchers who will present over the next. Our presenter today is Tamar Klaiman. Tamar is an assistant professor of health policy and public health at the University of the Sciences in Philadelphia. She conducts public health systems and services research and teaches public health policy and management, social and behavioral foundations, and disparities. She also advises MPH and health policy doctoral students. Her research focuses on using positive deviance methodology to learn from high-performing state and local health departments. She's collaborated with colleagues around the country, and the goal of her work is to share best practices with similar organizations in order to improve population health resources. She has worked in the areas of emergency preparedness and response, clinical health registries, and maternal and child health. And she did receive a 2-year PHSSR Mentored Research Development Award in 2013. So Tamar, go ahead and present.
Okay, thanks, Rick. Thanks all for joining today. I know many of you. It's nice to see you from afar. I'm going to talk today about learning from positive deviant local health departments in maternal and child health. And I just want to preface this by saying that the title is probably a bit of a misnomer, because really we're interested in learning from positive deviant communities with exceptional maternal and child health outcomes, and working with local health departments to try to find out why those communities have exceptional outcomes. Initially, I'd just like to acknowledge, like Rick said, funding for this project was provided by the Robert Wood Johnson Foundation Public Health Services and Systems Mentored Research Award. So I just wanted to thank the Robert Wood Johnson Foundation and acknowledge that resource. So the research objective for this project was to identify and learn from local health departments in communities that perform better than expected in maternal and child health outcomes compared to their peers. And we wanted to take into account local context, including geography, demographics, and finances. And you'll see how we did that in a few moments. So for those of you, I think most of you are probably familiar, at least somewhat, with positive deviance. Just to give you a little bit of a foundation, positive deviance has been traditionally used by that perform expectations. And in public health, it really started in global public health, where researchers would look at a community that had better, for example, child nutrition rates compared to other communities, and try to find out why some children were malnourished in one community and had better nutrition than another community. And what's important to note is that it's really defined by context. So you want to compare apples to apples rather than comparing a community in Iowa to a community in New York City. You want to compare similar communities. And context is really varied. It can include financial context, community context, human organization environment, leadership context, and even attitude. So it's important to keep that in mind when using a positive deviance framework, that context really matters. And the goal of positive deviance is to improve performance among like organizations or systems or communities. And so the nice thing about this framework is that you can really look at similar communities or institutions and allow those who aren't using processes that are effective to learn from their peer communities or systems. There are 4 steps in the positive deviance method. First, identification of high performers, then studying organizations using in-depth qualitative methods to develop hypotheses about why those organizations are better achieving than their peers. And then the third step is to test hypotheses in a statistically representative sample, and then finally disseminate best practices. Due to resource constraints, we focused on steps 1 and 2 in this project, first identifying positive deviance, and then studying organizations in depth using qualitative methods. And our hope is that at the end of this project, we'll be able to leverage some of the findings to test out our theories in a statistically representative sample. Of course, assuming that data are available, which can be a challenge. So we've used a realist evaluation framework, and this comes from Pawson and Tilley. And the idea here is that in order to achieve certain outcomes, there is an interaction between context and mechanisms. So context is the environment that a local health department might find itself in, the budget, population, demographics, geography, and those are things over which local health departments have very little control. Then those contextual factors interact with mechanisms, things like the type of leader that's in charge, the kind of partnerships that are developed, the types of services that are provided, most of which are under the control of the local health department, and those lead to specific outcomes. So an example might be that a large urban local health department would form, which is the context, would form formal coalitions, the mechanism, which might lead to increased referrals for services at that health department. Another example might be a suburban local health department in a conservative community might partner with local community health workers that are part of the community, which would lead to more discussion of safer sex in schools. We had a two-step process in our methodology. The first step was to conduct quantitative analysis to identify positive deviance in the states we included. And then the second step was in-depth interviews with those positive deviants to find out some more about these context plus mechanism equals outcome stories to try to start to get at what are some of the factors that lead to exceptional outcomes. So first I'll talk a little bit about the quantitative analysis and then discuss the qualitative interviews. We use data from the Public Health Activities and Services Tracking database, which is housed at the University of Washington. My research mentor is Betty Beckemeyer, who is the PI of the FAST database. We included local health departments in Washington, Florida, and New York because those were the states for which there were complete data sets. In Washington, we had 35 local health departments, Florida 67, and New York 48. We excluded New York City in our sample, and there were 9 additional local health departments for which we did not have complete data, which is why the New York sample does not include the entire universe of local health departments in the state. The data are uniquely detailed and matched annual maternal and child health related county level expenditure data, and they're also linked to service and outcome data for each state at the county level. We use multiple regression analysis, and if you think back to the context plus mechanism equals outcome framework that I talked about before, you'll see that this flows nicely from there. Our Z factors were those factors over which local health departments have little control, so these would be the contextual factors. Those include population size, geography, and the size of their budget. The X factors are variables over which local health departments have some internal control. These included variables such as assuring services through alternative providers, having a clinician as the top executive in a local health department, and the specific kinds of services provided by the local health department. Our outcome variables, there were 4 maternal and child health outcome variables that were of interest to us. We looked at teen birth rates, late or no prenatal care, infant mortality, and the percent of low birth weight. So initially, we included the Y variables to look at contextual factors that were related to our outcomes of interest. And then we added those variables that over which local health departments have some control, so the mechanism variables. We use likelihood ratio tests to determine whether the internal control variables improve the explanatory power of the model. And in most cases, it did not, which meant to us that there were some other reasons that local health departments were experiencing exceptional outcomes other than the quantitative data that we had access to. When we looked at outcomes where lower was better, we identified potential positive deviance as those with standardized residuals less than -1. And then we defined positive deviance as those local health departments that had consistently better than expected outcomes. So they had to have exceptional outcomes either over a 2-year period and or over multiple outcomes. And you'll see results of that in a moment. So we identified 50 positive deviant local health departments across 3 states, and we did within-state analysis rather than across states because of the variation across states, particularly in funding levels. There's such great variation that we thought identifying positive deviants across states would probably leave out many of the positive deviants that we would have identified within states. So in Washington, we identified 10 positive deviants, 24 in Florida, New York, and 16. And you can see that the percentage of positive deviants out of total local health departments is relatively consistent across the 3 states. 45 of the 50 local health departments had better than expected outcomes over 2 years, and 25% had 2 or more exceptional outcomes in a single study year. So we felt that our method for identifying positive deviants was at the very least consistent across states. So we had some confidence in our process. In this chart, you can see there's a few things I want to highlight. First of all, if you look in the first column, when you compare local health departments to positive deviants in terms of proportions, you see that by context, the proportions are similar. So there's a similar proportion of rural local health departments that are positive deviants as rural local health departments in the state. And that's the case across all 3 states and combined. Another interesting thing that we found was that in terms of expenditures, there's great variability across, even within states and even within context. So for example, if you look at Washington, positive deviant spending for total maternal and child health expenditures, the range is 0.73, so 73 cents to 11.71 per capita. But what's of particular interest, if you look at the highlighted sections, you'll see that in these cases, the mean positive deviant expenditure is actually less than the non-positive deviant expenditure, which although we can't read a whole lot into that, it did tell us that there might be some other reasons why these local health departments are positive deviants. And in no way are we arguing that local health departments don't need funding to improve outcomes. There's a lot of evidence that funding definitely has an association with improved outcomes. But what it did tell us was that there must be something going on in these particular communities that is not solely dependent on funding. And so our interest was finding out what are those things that are happening, particularly because local health departments have minimal control over the amount of funding that they receive. So this takes us to our qualitative analysis. We conducted 1-hour semi-structured phone interviews with local health department staff, and you can see here are some of the examples of who those staff, the title of those staff people. It varied from health department to health department, and we allowed them to decide who would be the most appropriate for us to talk to about their maternal and child health practice. Our interview protocol focused on 3 key areas: assessment and policy development, research and evaluation, and regulatory oversight. And we decided on those focus areas because of the Mays et al. Article that's noted here. In that article, they also noted emergency preparedness, but we left that out because it wasn't relevant to our outcomes of interest. We contacted 50 positive deviants. We have so far completed 32 interviews. 4 local health departments declined, mostly because they no longer offered maternal and child health services. And then we have 14 interviews pending. In Florida, we've interviewed 24 positive deviants, Washington 10, and New York 16. You can see in Florida and Washington, we're pretty happy with our response rate of 75 and 70%. It's actually higher than we expected. And our goal was not to be sure that we interviewed every local health department, but that we were able to get representation from local health departments in varying contexts, and we've been able to do that. New York, we're still working with to increase our response rate, and we're following up with local health departments as we speak. So I wanted to share with you some of the results from the qualitative analysis. We're still working on the on coding and analyzing the qualitative data. So please, just to be clear, these are preliminary findings, but we should have more finalized analyses complete by the Klaiman conference. So if you're there, please come to our session and you'll see some more up-to-date information from our findings. So the first result that we found was that partnerships are really important. And for any of you who work in local public health, I'm sure that this will not be surprising to you. But we found in particular community partnerships, school partnerships, and then internal partnerships were particularly effective in improving outcomes. So, excuse me, so all local health departments depended on partnerships, but the structure and implementation of those partnerships varies greatly. So for example, rural health departments tend to depend more on personal relationships and less formal partnerships because your neighbor may also be the school nurse and the other neighbor may be the police chief, for example. Rural communities depend in general on more informal networks, and local health department staff, at least among the local health departments that we spoke to, have been there for years and years, and they may know children of children. So they may see a patient who's pregnant whose mother came in when they were pregnant with her, for example. Here is just an example of a context plus mechanism equals outcome story that we found. In a micropolitan community, so this would be sort of like a suburban community that had low immunization rates, partnered with primary care providers, and it led to increases in immunization rates. Here's another example focused on building community partnerships. In this community, it was a rural local health department. They developed community partnerships, and it led to a great deal of community resilience in that area. So the next lesson that we've learned is that having clearly defined goals makes a big difference. And these are community level goals. And what we found was that these vary pretty greatly across both within states and across states. But what's important is that the goals are defined. So in some communities, the goal is direct services, and for a number of reasons, many local health departments have had to get out of this business, which is a whole separate conversation that we could certainly have at the end of this presentation. Many local health departments have shifted from direct service to population-based services, but across the board, they've really used evidence-based processes to identify what the goals are in the community. And so those processes include community health assessment and community health improvement processes. And then in some communities, the hospital community health needs assessment process has also been helpful, although that's varied, again, by location and context. So here are some examples. Here, a metropolitan local health department had reduced resources because funding has gone down. They shifted to population-based services from direct services, and that's led to improved community health outcomes. Many local health departments have experienced furious budget reductions, and funding has become much more prescriptive than it was maybe 10 years ago. And so a number of local health departments have shifted to population-based services and put resources much more into the social determinants of health rather than specific maternal and child health programs. And we saw that a lot where people were reflecting back on the practices that they did in 2009 and 2010 and said, you know, we really don't do those practices anymore. We've shifted our services and practices to focus much more on population-based services and acting as a connector for the community to reach services. And in some cases, that's been very successful, and in other cases, it's led to some challenges. What we also found was that local health departments are experiencing some pretty significant. What's particularly interesting is when you speak to a local health department director and you tell them that they've been identified as an exceptional health department, exceptional outcomes, 9 times out of 10 they say, "You're kidding." So there's a lot of unsung heroes in local public health, and they're really facing some serious challenges, and sometimes they don't realize how much they do for their communities. So one example of this is funding. This quote here is from a micro local health department discussing termination of home visits. And basically, when it came to basic budget decisions about what to preserve, it wasn't about local assessment data. It was really about basic public health interventions. And so you can see, again, that shift because of reduced funding, that shift from providing direct services to population-based services. And then also staff turnover has been a huge issue, which is, of course, in many cases directly linked to funding. And our hope is down the road that we can do an updated analysis with data from 2013 and 2014 and find out who has remained positive deviants over this past 4 to 5 year period, and what are they doing given the impact of the Affordable Care Act and the shift to Medicaid managed care, which has impacted a lot of these services. So some of the implications from, again, these are preliminary, but the first thing that local health departments have consistently said and recommended to other local health departments is to establish partnerships. And so the partnerships may include things like providing technical expertise, data analysis services, and administrative support, helping to connect community-based organizations to one another and also to the community and the population. And then another recommendation from many local health departments was to focus really on data-driven activities, focus on community priorities, what does the community want to see in conjunction with what data are available and what the data show, and then again focusing on population-based services, which is a shift we've seen in many situations. So in terms of the next steps of our project, by the end of March, we plan to have completed the New York interviews. We also plan to interview some negative deviants, although I hate to call them that. We'll just call them average local health departments. Our goal is to interview those as well to see if some of the things that we found in our positive deviants may be missing from our negative deviants, to try to validate some of the findings that we found. We hope to have our qualitative analysis complete by June or July. Again, by the Academy Health PHSSR IG meeting, most of our analysis should be complete. And then we will disseminate our findings. And so we plan to publish some policy and practice briefs for local health departments that are on the ground, and for policymakers that are making decisions about funding and priorities. We also, of course, plan to present at conferences like Keeneland and APHA and Academy Health, the sort of usual suspects, and then, of course, manuscripts. So before I conclude, I just want to thank the Robert Wood Johnson Foundation again, the phenomenal research assistants that I've been working with, Anjali Chinani and Athena Pantazis, who've just been tremendously helpful, all of our interviewees, and then our advisory council, with they're listed here. They include some phenomenal researchers and then some great practice folks. And without them, we really could not have gotten this this work completed. And we appreciate all of their guidance. And that is all I have.
Thanks, Tamar. It's particularly kind of relevant and fascinating given the continued decreases in funding we've seen in local public health agencies over the last, few years. So it seems like it's really relevant stuff to identify what might work best. So we've got two folks to comment on today's presentation. The first one is Betty Beckmeyer. Betty is an associate professor at the University of Washington School of Nursing and also an adjunct associate professor at UW School of Public Health. She's nationally recognized in PHSSR and has focused on structures and services of state and public health departments, particularly in relation to how they relate to health outcomes and reducing disparities. She's conducted quite a bit of research in the public health practice-based research network realm, working both with Washington's PBRN as well as with the National Network of Public Health PBRNs. She's leading several PBRN-related projects, in particular the Public Health Activities and Service Tracking Study, or FAST. And she was the research mentor for Dr. Klaiman's Mentored Research Award here. Betty, do you have any comments?
Yeah, thanks so much, Rick. You don't see my name on the Adobe Connect there because I wasn't able to connect due to my own technical problems over here. But I listened carefully to the whole presentation, and I've been working, of course, with Tamar very closely. So I just want to say a few things. This is super exciting research as far as I'm concerned, and as well as many of our practice partners, because some of the groundwork that we've laid that's led up to now what Tamar is doing has really identified, in some of our preliminary studies, identified some of the contributions of local public health departments to healthy outcomes, et cetera, and as well as some of the tremendous variation. So, but whenever I present a lot of that work, my public health department and practice colleagues are excited to hear this, excited to have some kind of validation, empirical validation of some of this work that they know sort of tends to have good outcomes. But they also say, you know, we're all doing something different, or what are we really doing that's having this, that's making this impact, et cetera. And some of the more kind of the more quantitative empirical work that we've done to date hasn't really doesn't dig in at that level. So I always tell them, you know, hold tight because it's coming, and that's some of this work, fantastic work that Tamar is leading around digging into what's really going on here, and how do we learn from those that really stand out. So I just want to say that this is super relevant to kind of the next phase of what people really, really want to hear and need to know. There's a couple other things that kind of stand out to me. Tamar, you made, I think you made the point that that there are a lot of these, that some of these health departments are saying that some of the shift that they've made to more population, to a more population level focus, it has, they perceive that as to have led to healthier community level outcomes. And I want to make sure, I want to verify that that's what I understand you to have said. Is that true?
Well, I think that in some cases they've felt that they have been in a better position to affect population health outcomes by shifting services to population-based services. So, for example, one local health department director talked about doing home visits, and he said, you know, how many families can we visit in their home based, you know, with the money that we have, as opposed to doing, you know, large-scale immunizations, for example. And so with limited resources, sometimes shifting those services to population-based services and helping those folks get access to resources that maybe are being provided elsewhere in the community can lead to, you know, more effective public health interventions sort of across the board. Okay. And that varies. Okay. Not everybody feels that way.
Okay. Because I think this has really interesting implications, I think. If some of these positive deviant health departments have indeed made more of a shift than others towards these more population health outcomes and putting more resources into the social determinants of health, et cetera, it will be really interesting to see if over time, as you suggest, over time, do they remain positively deviant? Probably the shift is probably pretty a relatively recent shift, and it'll be really interesting to kind of examine this over time. And or does that shift and its implications for the local community's health, does that vary? As you suggest, you know, it really differs. These activities and how they're performed, et cetera, are really different, as we know, from rural and urban communities, et cetera. And so that relationship may be a little different. So to me,
I think just Betty.
Sure, go ahead.
I just was gonna say that's a really important point, and you know, we're assuming that example I just gave you, there were resources in the community that could backfill the services that weren't being provided any longer by the health department. That is not the case in every community. So if you're looking at, you know, a rural local health department in a small community in a remote area, things may look very different.
Mm-hmm. And I think that's what's really important about what you're doing here, is to drill down and so that we don't run the risk of painting things too much with too broad a brush. So we really understand sort of the nuances of some of these shifts in communities depending on what the local resources are, et cetera. So I think, you identified some really interesting outcomes and more research for you in the future and for all of us. I also think the focus on data-driven activities is really interesting too, and really sort of supports the need for us to correspondingly develop, produce, and make those data more accessible to people, because I feel strongly, or we've found quite a bit in others of our research too, that that people often don't find the data adequately accessible to them for whatever reason or in whatever form or et cetera. So I think those are the sort of really things that jump out to me, and I'll pass the baton off to the next.
Thanks for those comments, Betty. Tamar, do you have anything just in general to say to respond to those comments?
I mean, it's exciting to hear that this is, of course you want your work to be relevant, so I'm glad I'm not the only one who thinks so. I will say that, many of the folks I've spoken to at local health departments are, they're really excited to talk about what they're doing. I mean, even, the challenges that they're facing, and many of them are facing some serious challenges. I think they really appreciate having someone talk to them about what's going on the ground, in their communities. And, I think, like Betty said, hopefully some of the findings from this work will be relevant to people who are doing this. If you're not trained as a researcher, you could put up all the, logistic regression graphs you want, and folks look at it and they say that looks pretty, but it doesn't have as much meaning as I think sometimes actually having the conversation with them.
And can I add one more thing, Rick and Tamar, and then I did say I'll pass the baton. But what's also particularly interesting about this, and I know Tamar has had situations where when she's contacted people, they'll push back and say, no, that can't be us. We're not.
Yeah.
We don't stand out. And so it's kind of fun to dig around and find out things that people didn't even realize they were doing or had this potential for an impact, et cetera, which says we're fine. She's able to dig into model practices that wouldn't have otherwise been identified when we otherwise need to rely on those that step up and say themselves that they have a model practice. These are folks that didn't even realize they may have been doing something particularly beneficial.
Great, thanks. Our next respondent today is Jerry Reed. Jerry is the Director of Public Health in Clinton County, New York, a rural community that borders Quebec to the north and Lake Champlain and Vermont to the east. She oversees a full-service health department, which is presently on the FAB agenda for accreditation approval in March 2014. Prior to becoming director in 2012, she was the Nutrition Services Coordinator for Clinton County and oversaw preventive nutrition and health education services in the department. She's been a public health employee for over 25 years, holds a degree in clinical nutrition, human nutrition administration, and a graduate certificate in public health. Jerry, go ahead.
Good afternoon. I am one of the local health departments that Tamar mentioned was very surprised. So when they called and said, you have some really good outcomes and we'd like to talk to you, at first I ignored them because I thought they surely can't be talking about us. So it was pleasantly surprising to find out, but it really involved us delving deeper into what I was feeling we weren't doing appropriately. And as I explained during the interview, what we have done locally is, as most public health departments have, we've gone through many transitions on the local level over the past few years. That said, many local public health departments were structured originally in more rural areas as nursing services and did a lot of home care-based services. We, as many other health departments did, at least in New York State, sold our home health care program about 3 years ago. We ended up transitioning a lot of nurses who were used to doing that one-on-one model and had to really reacclimate them to public health. And that has been an ongoing challenge and a learning curve for all of us. So what we did with our prenatal program was we just actually went through a complete evaluation of it to look at outcomes, to look at visit numbers, to look at what we are actually doing and if it makes a difference. Because we're acutely aware of staffing needs, staffing shortages, and what's our best impact that we can make with the staff we have and what should we be doing. So we're right now looking at restructuring that program. One of the challenges we faced was funding, and not funding for staff, but funding for the services we were providing at one point, which was really based in Medicaid services, that we would be able to contract with physicians to provide services that they would then get funded and we would get funding for, and that no longer occurs. So what we have to do is look at who are the highest risk people in the community that will not get service and would benefit from a one-on-one visit with a public health nurse who could provide some kind of guidance. Are those people who may have more mental health issues, which is what we're finding? Are there people with substance abuse issues, which is also what we're finding, and other needs? And what can we do about that that doesn't duplicate some of the services we have for maybe lower risk people? And so we're working in cohort with another group, and that's part of the partnerships that have been mentioned, that is very important to make sure there is no duplication. And I think for public health, it's still hanging on to that one-on-one model in some sense, but we're doing it on a much more limited and more prescribed basis to get outcomes that we think will be more meaningful. And then looking at the newborn postpartum period to maybe provide more guidance and anticipatory guidance for families that may be at higher risk and need those for better outcomes overall. I think that's about all I have to say if anybody has questions.
Thanks, Jerry. Tamar, do you have anything any kind of response to that?
Well, I mean, Jerry, first of all, thank you for sharing your experience and participating in this project and on today's call. And, you know, I think a lot of the things that you brought are challenges that are being faced in local health departments, at the very least in the 3 states that we interviewed, and my guess is probably in other places as well. And, you know, your story is very similar to other stories in communities that are similar to your community and may look somewhat different than, you know, if you go to a large urban local health department that used to provide home visiting services, they may be able to contract all of that out and have all of that covered. And so I think you just highlighted the need to take into account all of these contextual issues that come up, and that you can't, you know, that you can learn from those who are in a similar situation and in a similar environment, and some lessons cut across all different kinds of contexts. But when you really drill down, there is some variation, and we need to be aware of that and thoughtful about that. And so I think you just really highlighted that just based on even your own local health department's experience.
It's difficult when you have staff that are used to doing the one-on-one visit model, and that you have to transition them for a more population base. And one of the commentators was talking about perhaps doing, or perhaps it was you that said you can do more kind of group kind of settings than doing the one-on-one, or doing more in immunizations. And we agree, immunizations are very important, but there's still that subpopulation that you can say that really does have a piece in public health, because that's the gap filling, and that's
right.
Part of what public health has to do. So you have to assess the needs in your community, and if nobody's providing that services, you step in and either get somebody to do it, or you fill that gap temporarily until something can be done about that. So I feel that's what we're doing right now. We're looking at that gap service. We're deciding, are these people who aren't going to be getting service or aren't getting the quality of service that we think they need to affect outcomes, and then we can move on to something else that we have assessed that is a need. But it's really getting the staff involvement to understand that it's not all about making one-on-one home visits. It's a whole different model. And I think rural counties have struggled with that as we've divested our home care services and really got on to true public health. So it's a learning curve for everybody, absolutely.
Great, thank you. We're open for questions and discussion. If you have a question you'd like to ask Tamar or our commenters, please type in the chat box at the bottom of your screen. So Tamar, I have a question.
Sure.
Regarding your research, you found some really interesting stuff. You looked at 3 states in particular: Washington, New York, and Florida. And those states are very kind of unique from a public health standpoint. They're some of our, I'd say probably some of our higher performing states. So I'm just wondering, how I guess generalizable or relevant do you feel that your findings are to public health practice in the remaining 47 states that we look at?
Yeah, I that's a totally fair question, and I think it's a challenge. Although I will say that many of the things that we found have been the case, across even just the 3 states, which actually are very different in terms of their public health, in terms of how the public health system is set up. Our hope is that there's an issue of data. We just don't have complete data for all of the states, and I just typed in a methodology question. Which may sort of get to what his question is asking, that, this full disclosure, the sample size is really small. We may have included positive deviants. We may have found those that are positive deviants that aren't actually positive deviants, and that's absolutely a limitation. The hope is that we'll get to step 3, and with increased data and access to data, we'll be able to test some of these theories in a larger sample. In the meantime, though, I think the lessons that we've learned can still help those local health departments that are struggling, that are trying to figure out how to decide what services to provide in a very changing environment. And if we can learn from the practices that are working in some communities, even if we've misidentified them as positive deviants, I'd rather err on the side of including too many than not enough, because I still think that we can learn from the folks that we talk to. And, the lessons that we've learned, there has been consistency across context and across even across very varying systems.
Great. And as you said, Glenn Mays has typed a question. This is kind of a question related to some degree with what we've just discussed, as you said. So Glenn's written, on particularly regarding your methods, so regression model misspecification, omitted variables, and heteroskedasticity are sources of estimation bias that could inflate residuals and cause communities to appear positive or negative deviants. So how can you distinguish model misspecification from true positive deviance?
Yeah, so this is, first of all, Glenn, thanks for just going right to the methods on, question number 1. Appreciate that. But, we've tried to address this by sort of creating an index where we've only included those that have been identified over time and multiple years. So hopefully excluding those that were not actual positive or negative deviants. This is one of the challenges of such a small sample size and so few, and we've just sort of tried to do the best that we can with what we've got.
Glenn is typing another question, but I have one.
Okay.
So your slide on expenditures, you noted that it seemed like the positive deviant expenditures were often lower than the non-positive deviant expenditures. Mike, do you have any sort of like just general, I know you addressed it a bit in your presentation, but just any kind of general thoughts about why that might be the case? Could that be related to, let's say, departmental efficiency or things like that? Or?
Yeah, that's actually a great question. So actually Rachel Hagen and I have been talking about looking at efficiency measures in the positive deviants to find out if maybe they are more efficient than the average or negative deviant local health departments. So stay tuned for that. And thanks for letting me plug that upcoming work. And that's also much of the reason why we're doing the interviews is to try to understand why that might be. What are they doing? What's going on in the health department that is that even with fewer funds, they're getting better outcomes.
Glenn's kind of follow-up question was, were your deviants consistently deviant in multiple outcome measures?
Yeah, so Glenn, I'll actually click back to one of the slides that I presented, and it'll show you how many were. Okay, so 45 of the 50, so 90% had better outcomes over multiple years, and then 50% had 2 or more exceptional outcomes in a single study year. I don't know if that answers your question. Where they can, yeah, so 50% of them were consistently deviant in multiple outcome measures.
But I have a question in
the. Okay.
You conducted these 1-hour semi-structured phone interviews with departmental staff. Could you go into a little more detail about how you kind of created the phone interview instrument?
Yeah, so that's a great question. So we actually worked with our advisory council, which includes researchers, public health systems and services researchers, and practitioners. And we organized it by those 3 overarching areas that I noted before. And then we asked questions within those areas. We drafted them, our internal research team, and then we worked with the advisory council to hone in to be more specific about the questions and to be sure that we were asking questions that were relevant.
Great. And kind of a related question, this is to clarify, I think you addressed this before in your presentation, but looking at kind of your slide about you had 75% response rate in Florida, 70% in Washington, and then 44% in New York. Did you notice any differences between the departments that responded and didn't respond? Were there like any kind of noticeable things that might be different between the departments?
Well, it's hard to tell. Rural local health departments are particularly hard to track down. I think it's just because folks are so busy, and many of them, they don't actually believe that they're exceptional. So that's been an issue. And we actually, New York has been the most recent one that we've reached out to, which is probably why it has such a low response. Taken some time. One thing that was really helpful for us in Florida and Washington is that we actually had folks who were connected with local health departments, either a local health department director that knows many folks in the state, or in Florida, Les Beich, for those of you who know him, he connected us with many local departments. So that was, that sort of personal connection was really helpful. I don't know. I mean, I'd sort of have to go back and analyze the differences between those that responded and those that didn't. But nothing jumped out at us as, these factors showed up in the ones that didn't show up in the others.
Great. Nathan Hale has typed in kind of a comment and question. Nathan's comment and question is, Nathan says, I think the workforce issue when transitioning to a more population-based model is perhaps underappreciated. In your research, was this discussed or commented on during your interviews?
Yes. Wonderfully so. Particularly in communities where local health department staff are used to doing direct services, so people who are, maybe public health nurses or trained as clinicians, going to a population health model is a huge shift for them. It's a huge transition for them. Some people are more comfortable with it than others, which I think is the case for all of us, having to learn new skills and think about things in a different way. So it's definitely been challenging, and it's actually led to a lot of health departments having a fair amount of staff turnover, where public health nurses are saying, you know what, I want to be doing home health visits. I don't want to be doing, health education to large, at a health fair. And so it's led to some staff turnover. In some cases, when the home health agency, for example, has been sold off to a private entity, a lot of the staff has gone with it to remain working in that environment. So it definitely has come up again and again.
Great. Looks like we have time for a few more questions. Anyone? Looks like Glenn is typing a question in right now. So all right. So Glenn's question is: can the qualitative arm of your study reach stakeholders outside the LHD who may be driving positive
deviance, yeah.
for example, schools, family planning clinics, OB providers, et cetera?
Yeah, that's a great question. So the challenge is timing and resources, but Glenn, our hope is that we can actually, the next phase of this work is going to be to identify positive deviants who have remained so. So the data from this study is 2009-2010. Since we've interviewed most of the positive deviants in this sample, our hope is to see who remained positive deviants after the external shock of the 2008 financial crisis and then the ACA. And then what we'd like to do is reach out to those other community agencies and really delve deep into the communities that have remained positively deviant beyond the local health department. So our hope is definitely to do that work. Glenn, you're kidding me.
Glenn's comment is can't resist. No agency control over budget. Really?
Not no agency control over budget, but in terms of, a lot of local health departments get block grants from the state, and they say this is, you have to spend X dollars on maternal and child health or X percentage on maternal and child health. So if they do that budget, there may be some discretion, but in a lot of cases, the amount of budget, it can vary. Now, in some local health departments, those with the expertise and the resources, they can apply for grant funding, for example, for for lactation consultant training, for example, or for other kinds of prenatal care services. Agency control over a budget, but arguably limited control over agency budget. And whoever is organizing Keeneland, if you could put Glenn in a session at the same time as mine, so he's not in my session, that would be really helpful. I'm just kidding.
Looks like we may be finished with anyone who has a question. Great. Tamar, thanks so much for your time. That was a fascinating presentation, and thanks everyone for your participation. Archives of all our webinars are available at the website you see on your screen. Upcoming webinars in March are Wednesday, March 4th, Wednesday, March 11th, and Thursday, March 19th. The 4th and 11th webinars are both folks who received our Mentored Research Development Awards. We have another Mentored Research presentation on April 1st, and then one on April 8th as well. And as a shameless plug, please don't forget that Tuesday and Wednesday, April 21st and 22nd, 2015, are the 2015 PHSSR Keeneland Conference held in Lexington, Kentucky. Thanks again for your participation today. For more information, please feel free to contact Ann Kelly at the email shown on your screen. Thank you so much.
And